My name is Morgan Harris. I'm a health program specialist with the Utah Women and Newborns Quality Collaborative, and I oversee the AIM initiatives here in Utah. This is a third in a series of telehealth learning sessions for the AIM Perinatal Mental Health Conditions Patient Safety Bundle. And these learning sessions we are calling ACT sessions, which stands for Ask, Collaborate, Teach. The goal of these learning sessions is to help you think further about the Perinatal Mental Health Conditions Patient Safety Bundle. And we hope that you'll ask questions, collaborate with us, and teach your team about what you've learned. If you ever need any resources or support, please reach out to me. I'll put my email in the chat in a bit. And I am super excited to introduce Amy Rose White to talk about perinatal psychosis and suicidality. Amy Rose White, LCSW PMHC, has been an integrative perinatal and trauma psychotherapist in private practice for over 16 years. She founded the Utah Maternal Mental Health Collaborative, now Postpartum Support International Utah, as well as the Well Mama Maternal Mental Health Services in Eugene, Oregon. Her passion for trauma-informed care and child abuse prevention has led to a 27-year career in social work with perinatal and multi-stressed families, including 2 decades as an international speaker in the field of maternal mental health. Amy Rose is also the proud mother of 2 fantastic young men who know quite a bit about women's emotional wellness. So now I will turn the time over to Amy Rose White. Thank you again for being here, Amy Rose, and thank you all for attending during your lunch hour. I'm sure you'll talk a little bit about this, Amy Rose, but I just want to preface that we understand that this topic is quite heavy, so please feel free to step away and take a break anytime that you may need during this presentation. All right, thanks, Amy.
Thank you so much for that, Morgan. I'm actually so excited to be here talking about, yes, what is indeed a heavy topic, and we're actually going to start from that place. As we begin, we've got about 100 slides to cover. I'm not going to go into great detail into every single one. Feel free to ask questions as we go along. Just interrupt me or enter them into the chat, and Morgan can maybe I'll pause from time to time and see if there's any questions as we go along. And then we will have time for some questions at the end as well. And you can see where our agenda is going to go. So you can kind of think about that as we move along. And again, thank you so much for allowing me to share this information. So this is our agenda for today. We're going to start with just covering some basic information, data around risk factors. We're going to talk about some specific high-risk diagnoses, such as bipolarity and psychosis or thought disorders. We're going to focus quite a bit on prevention and then, of course, intervention. But before we do all that, what I'd like to note in my presentations is a reflection of the way I work therapeutically with folks. And that means that our own ability to be with such subjects, including discomfort and pain, because that's what these really elicit in us and in the clients and patients that we serve, our ability to do that is proportionate to the ability that we have to hold the space with our clients and patients. So just remember that the more we can meet ourselves there in the depth of our own psyches, the better we can be prepared and reflect a very safe container for our clients and patients to emerge from some of these crises on the other side, hopefully in a state of healing and greater transformation. So right now, I'd actually like everyone on this call to just locate with your awareness and your breath where the terms psychosis, suicide, we will be briefly covering filicide as well. Just what is your nervous system's response to those terms? In my opinion, we have, as a collective, not recovered from the pandemic intensity in our nervous systems. We've been in wartime, and now we've just had a really, historic event happen over the weekend that has jarred and activated the nervous system of many people around the country and the world. So I want to just take a moment to honor that, to tune in, to listen, just what's present, what is here right now in this moment, and simply to acknowledge that in ourselves. I see you. Maybe it's a tension in your chest you're noticing. Maybe there's a pit in your stomach. Maybe you're really tired because you just had lunch. Whatever it is, without judgment, simply saying, I see you, I feel you, and I love you. And from that place, we will dive in just remember to continue to keep this awareness present and attend to yourself. Feel free to reach out to me after this. I have carved out some time. If you need to chat about anything, I can also make time later in the day, someone that is close to you, your own therapist, family member, friend, etc. Time in nature, just eating really well today. Anytime we discuss topics like this, our nervous system will respond. Even for those of us, for some of you might work in an emergency room situation or, with very severe or significant medical situations. So you're used to maybe bypassing the danger signal in your body. And I just invite you not to do that today, at least in this moment and later today, to really practice attuning to your own body's experience and awareness and share that with someone else if you can. This is the greatest model we can give our clients and our patients around healing. So given that, the reality is every single person we work with has some risk for suicide or psychosis, if we're just talking about the perinatal population. How likely is that really to happen? In mental health, when we become a counselor, they say it's not if, it's when. I have yet personally to have a client die by an acute suicide attempt. I do have someone who died of his alcoholism. But it's one of those things that we all fear, someone becoming psychotic, taking their own life, taking someone else's life, or dying of suicide related to a multitude of potential risk factors. So as is probably not surprising to you, we know that suicide is the leading cause of maternal death in the first year postpartum. It typically is between 1 and 3 in that first year. Women who are pregnant and postpartum are still statistically less likely to commit suicide than the general population, yet it's a leading cause of death in that window of time. There's a higher risk. One of the higher risks that is most salient is prior inpatient admission. We know that with people who have perinatal psychosis, it's roughly 1 to 3 per thousand will have psychosis, and 5% will die by suicide, and 4% will kill one of their children. Filicide just means any child, son or daughter. When it comes to maternal mortality in Utah, the most recent PRAMS data is the following. Leading causes were accidental drug-related death and suicide, 25 and 20% respectively. Most of those were associated with a current or past mental health condition, and 92% were deemed preventable. When we look at larger data sets, this Danish study of 1.5 million women is one such one, shows that compared to mothers with mental illnesses not related to giving birth, women are much more likely to commit suicide in that first year. And here are some important suicide risk factors specifically, not just talking about psychosis. We're isolating suicide for right now. Pregnancy loss, IPV, intimate partner violence, any history of trauma, comorbid substance abuse, emotional dysregulation, poor sleep, interrupted sleep, won't be a surprise to most of you. Any other comorbid psychiatric diagnosis, obviously such as MDD, major depressive disorder, otherwise known as postpartum depression in the perinatal period, any history of suicidal ideation or behavior, financial instability, medical issues in the infant, HIV status, maybe higher in the first trimester, and primiparity, first baby. They usually occur between day 43 and 365 post-pregnancy. Some other risk factors are family history of suicide. That's a huge one. We always want to make sure we're screening for family history. I always ask close friends, distant relatives, extended family as well. Impulsivity, again, any other affective or anxiety disorder, younger maternal age, unpartnered, unplanned pregnancy, non-Caucasian race, shorter illness duration, meaning that the mental health condition came on quickly, and there was a short period of time between the symptomatology and the attempt or the successful suicide. Interestingly, severe vaginal laceration. Women are more likely to kill themselves who have a severe vaginal laceration than a cesarean section. Again, poor sleep and abrupt discontinuation of psychotropic medication. When we talk about suicidal ideation, meaning thoughts of suicide, there's a really wide spectrum of those. They tend to be you're highly predictive during pregnancy of postpartum depression afterwards. They include the wish to die, thoughts of killing oneself, the intent to kill oneself. They could be thoughts, beliefs, images, voices, etc. They may or may not include intent, and therefore, one of the things we'll be talking about is simply disseminating passive versus active suicidal ideation, which is kind of what it sounds like. Passive is more like I often ask clients this, do you ever just wish you wouldn't wake up? Or could, go on a vacation and never come back. Versus I have a plan, I know what I want to do, and I have a timeline for doing it. That would be an active SI. So sifting through differential diagnosis is really important. That's just diagnosis, diverse diagnoses, and diverse symptoms. Diagnosing diverse symptoms is important for those of you that don't do medical shorthand. I'm not an expert at it. I just have like a few that I use in my own notes. So obviously the populations that are highest acute risk that we're going to be able to catch, given the wide variety of variables that we have, are those that have untreated and escalating major depressive disorder in the perinatal window of time, those with existing or current or manifesting bipolar 1 and 2 diagnoses, and anyone with a thought disorder, including perinatal psychosis, especially if those are combined with substance use disorder. I would argue that even just substance use without the disorder piece puts people at risk, but we don't have a lot of data stratifying those details. And I'll speak a little bit more about that as we go along. It's particularly relevant because the use of psychedelics has become so common and better research in terms of treatment for major depressive disorder, but it does not come without risk, and psychosis is one of them. So again, just to refresh your memory, we've got a lot of perinatal diagnoses that are potentially in front of us when we're working with folks, including generalized anxiety disorder, obsessive compulsive disorder. If that is untreated and a person doesn't know what they have, they think that they're a bad person who's having intrusive images of harming their infant, and how could, their infant would probably be better off without a mother who could possibly have such thoughts. That can lead to suicidality. Obviously, we have psychosis, sleep deprivation, medication reactions, substance use abuse. We need to know what we're working with. Is it unipolar? Is it bipolar in terms of mood? And that's what I call the PPD imposter, which is bipolar 2. So we're not obviously going to go in extensively into differential diagnosis, but we will be talking about why they're important. And Morgan, you interrupt me. I get going in the flow and I can't see anyone now. So if anything comes up, please just interrupt me.
This will do.
Oh,
Thanks, Amy. Amy
okay.
Rose.
I'm just looking at the screen right now. So the characteristics of bipolarity in general are really important to understand in terms of risk. This is almost always a recurrent illness. It is associated with severe illness-related morbidity and increased medical mortality. About 10 to 20% of patients with bipolar 1 or 2 will die of their illness by suicide. That is a large number of people with that illness. In perinatal people, the data is pretty conclusive. Like it agrees around this roughly like 67% of this small case study, but you'll see that in lots of other studies as well, had a postpartum mood episode within 1 month of delivery. Other studies will suggest it's more like 80. The recurrence rate in this small case study was 100%. Other studies look at around 20% of women with BP reporting postpartum mood episodes, mainly of the depressive type. I think the literature is more on the higher side, but I wanted to include diverse data sets. And then the risk of hospitalization is up to 23 times greater within 30 days of delivery for women with bipolar postpartum depression versus non-postpartum women with bipolar disorder. So the perinatal window is super high risk. It is a great time of vulnerability. And interestingly, in the largest data set, we have of 10,000 women who were diagnosed clinically with questionnaires who qualified for having postpartum depression. 25% of those who were positive actually ended up with a bipolar diagnosis. So a quarter of those, because it was isolated, wasn't a new diagnosis. It began with a postpartum, either depressive or manic episode. that leads us to some really marked gaps in care when we're talking about screening for postpartum depression if we leave bipolarity out of the mix and the picture. So depression arising in the postpartum period is often misdiagnosed as unipolar major depressive disorder, which results in a delayed initiation of appropriate treatment. And it can involve the inappropriate treatment with an SSRI, which you would never do as a standalone treatment for someone with a true underlying bipolar diathesis, because it can initiate mania. And I have seen it, or hypomania. So we don't have any pharmacological or psychotherapeutic studies of bipolar postpartum depression to really guide us in clinical decision-making, unfortunately. We don't have screening instruments specifically to help us suss this out, but we're gonna today talk about what we do have and how we can cobble what we have together to lower risk in the people that we work with. So these I'm going to go really quickly through these 3 slides because they're just data bringing the point home that so many women who screen positive for postpartum depression on the EPDS, the Edinburgh Postnatal Depression Scale, will actually end up with a bipolar diagnosis later. Roughly 20, 21, 25, somewhere around there. Verinder Sharma he obviously has a special interest in this, like so many of the studies in my citations will be done by Sharma. But in this one particular study, like 54% of 56 outpatients seen consecutively with a referral diagnosis of PPD were re-diagnosed as having lifetime diagnosis of bipolarity. And that's shocking to me. So this is just more with the same kind of information. 14, 20%, we keep kind of seeing those statistics with the conversion from PPD diagnosis to bipolar diagnosis, compared to 4% of women with the first psychiatric contact not related to childbirth. And more folks who were inpatient admissions ended up with those conversions than outpatient. So what do we take away from this? Psychiatric episode in the immediate postpartum period significantly predicts conversion to bipolar affective disorder in the follow-up period. So any manifestation, especially if it's new, and I have a bunch of slides on that, can signify a possible underlying bipolarity, particularly if that person has never experienced mental health issues before.
Amy Rose, we do have a question in the chat for you.
Great.
The question is, are you considering a positive EPDS score 10 or higher?
Mm-hmm. Correct.
Cool. Thank you.
Sure. The literature generally, like there's some debate, is it 10? Is it 12? The general consensus is to err on the safe side and use 10. And I believe all the large organizations have kind of settled there. And then individual hospital systems, when they're doing universal screening, they kind of just determine from there what they want to do. I believe the recommendations are 6 and above for fathers. Okay, so again, what you're looking at could be MD, a major depressive episode and disorder, or it could be the onset of bipolarity. And this person could develop hypomania or mania later. Hypomania is just soft mania, basically. It's talking more rapidly. It's in multiple ideas. It's a less of need for sleep, but it will look more functional and interrupt daily functioning less than mania. Mania, the person tends to seem markedly different than before they became manic, and mania can become psychosis. That's your bipolar disorder 101 in 5 seconds. So when we talk about diagnoses, that's essentially what I'm referring to. Is we want to make sure we want to do our best to ensure folks don't become hypomanic or manic, because that can become psychosis, and psychosis requires immediate psychiatric assessment and typically inpatient. And hypomanic episodes can also put someone at risk for psychosis. So bipolar 2, because it is so much more high functioning than bipolar 1, because of that hypomania, that like soft mania. I shouldn't laugh, it's not soft for people who experience it, but some people who have bipolar 2 diagnoses actually don't prefer to be treated because they feel most like themselves when they're hypomanic. They get a lot done, they feel energized, they feel alive, but it still puts them at risk, unfortunately, for mania and psychosis. So the next thing to be really aware of in the data is what we call first episode postpartum depression versus first episode non-postpartum depression. So the data basically suggests that the very first time a woman has perinatal, I would say even anxiety, but the data is looking at depression. The first major depressive episode happens in the perinatal period during pregnancy of the first year postpartum. That person is at a much higher risk of receiving a bipolar diagnosis later. In those same folks, we're going to see more hypomania and mania in first degree relatives. That's why one of the questionnaires we cover asks quite a bit about family history. You're more often going to see psychotic symptoms, what we call atypical features, meaning mixed. So it's kind of all over the place. This is what's unique about the symptomatology for perinatal women, is it's mixed. Tends to meaning agitation and depression and kind of being all over the place in the same cycle. A younger age at onset, higher number of prior episodes of short duration, people who have switched multiple antidepressants, seasonality of mood episodes, as well as mood episodes with free intervals were found to be more frequent in people who had depression first episode postpartum. So why does this make our job so much more complicated? Because there's this normal high. For any of you who have had a baby, you've got a lot of adrenaline, cortisol, and norepinephrine surging through your body, especially in the first 24, 48 hours. So that high post-childbirth, that could be part of the normal postpartum. I put joy here, but I really should have put just biochemical marker. Of course, there's joy, hopefully, for a lot of people, but it can also be traumatizing, yet your body is actually in that situation even experiencing more adrenaline, cortisol, norepinephrine for a longer period of time versus a mixed presentation of bipolar postpartum depression. So it's tough. It's tough to know exactly what you're looking for. So we need to, kind of have our spidey senses on when it comes to this, especially if we're working with someone in those first days and weeks. Bipolar manic episodes are typically discrete, meaning whereas manic symptoms occur within depressive episodes in major depressive disorder with mixed features. However, with meaning that they're kind of different. We see like the mania here, or we say, okay, you have MDD, but you have mixed features. This kind of can look like a mishmash of a lot of things. Psychosis can occur with either bipolar postpartum depression or postpartum from major depressive disorder. In my personal experience, I have seen that with women who are extremely sleep deprived or had a reaction to a medication or used a substance. Personally, it's tough to find the data on that, but it's important to know that anyone who has depression can potentially have a psychotic episode. It does not inherently mean we're out of the woods for that risk factor. And it also doesn't mean that if you have psychosis, you automatically get a lifetime diagnosis of bipolarity. We were doing that a decade ago. I think that's happening less. And we're going to talk more about that when we get closer to psychosis. Just checking my time. Okay, so screening. You all know this. We got to use the EPDS. And what do we do for bipolar disorder? We use the MDQ. It's fast, it's copyright free, it's 10 questions, and it really helps us differentiate bipolar disorder from unipolar disorder. And I put this in because there's a lot of people who they've lived with bipolar disorder their whole life. Perhaps this doesn't manifest for the first time perinatally, and they simply don't know any different. And no one has asked them these questions, which we'll get to in a second. So here's some things that are really high risk factors for bipolarity. Any first degree relative, such as a parent or sibling who has bipolar disorder or what they used to call manic depression. So I always ask people, does anyone have a diagnosis of blah, 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 including bipolar disorder? How about anyone where they say they have manic depression? Anyone whose mood was really up and then really down? Like I qualitatively describe what that means because so many people have bipolarity and they never got a diagnosis. A lot of people grow up in environments like that. Periods of high stress, such as the death of a loved one or any other trauma, I would argue any major sleep disruption or change to their social rhythm, and then drug or alcohol use or abuse. Basically, we need to do a really careful assessment if we can. The MDQ makes this much easier if you are working in a clinical practice, such as a medical setting, and you don't have an hour like I do to ask a bunch of family history questions. The MDQ will really save your butt here. But we need to ask for family history. We're looking for subtleties that might be more nuanced than, okay, we're in the clear because no one first degree has a bipolar diagnosis. We want to be in tune with our clients and our patients' overall affect and their intensity, the changeability of their presentation over time. We want to listen to stories. I remember I had provided couples counseling to people for quite some time before a story came up about a time that, one night in the middle of the night, he just decided to get on his bicycle and cross the country that he lived in at the time. I believe for like 2 weeks, like got on a bike in the middle of the night and drove across this country in Europe. And I was like, it's like couples counseling. I didn't give them the MDQ, so I later diagnosed him preliminarily because I always, with bipolarity, send folks to psychiatry for confirmation of that diagnosis, but with bipolar too. And then he did much better on a mood stabilizer. Lamictal is the newer generation that worked for him. So that's an example of how, like, you really want to listen to stories about times where people didn't need to sleep, times where they talked more, had lots of ideas, maybe had sex with multiple people and didn't actually intend it. It was kind of out of their character. Um, Hypersexuality can be part of mania and hypomania. And again, we're not going into all the, we're going to have a whole nother presentation on differential diagnosis of bipolarity. So that's a talk for another day. But we want to involve family members' stories and get some context if we can, using the NDQ and any substance use screening questionnaires will really give us a head start. So here's just the screenshot. Sorry, it's a little blurry of the MDQ. So the criteria is you want to screen further if they answer yes to 7 or more of the events in number 1 and yes to number 2 and moderate problem or serious problem to 3. And this is it. I know you probably can't read this. I cannot read this, but it's asking questions like, has there ever been a period of time when you're not your usual self? And so everything under 1 is predicated on that qualifier. Has there ever been a period of time where you were not your usual self and you felt so good or so hyper that other people thought you were not your normal self? You're irritable, much more self-confident, got much less sleep and didn't miss it, much more talkative, spoke faster, yada, 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 much more energy. And then asks number 2 is, have those symptoms happened at the same period of time? How much problems did they cause you? Number 4 asks about blood relatives, children, siblings, parents, grandparents, aunts, uncles. Do they have manic depressive illness or bipolar disorder? So it gets that old language that people still use. And then, has a health professional ever told you you have manic depressive illness or bipolar disorder? I am embarrassed to admit that more than once, I didn't ask that question, and later it turned out that there had been other providers that had given them a diagnosis like this. So that's a great question that I now always ask. So again, another slide on suicide. It's just bipolarity is associated with higher rates of suicide than any other psychiatric disorder. More likely to complete, unfortunately. Okay, I'm just going to pause here. Any other questions at this moment?
There aren't any in the chat, but anyone feel free to either type your questions in the chat or unmute yourself and ask a question if you have any.
Okay, so we don't have a lot of good data on the long-term effects, but we know that it's related to suicidality, perinatal for sure. Again, this is that 10,000 women study, 22% of depressed postpartum women have bipolar diagnoses. Okay, so you just want to suspect it, basically. especially in women who respond to antidepressants with mania, hypomania, mixed depressive episodes, or if you ever, I wish I could see all of you, but if we were in a room together, I'd say, have you ever had a client who took an antidepressant and the next day called you and said, I feel amazing. This is so great. I'm healed. Not good. That means, because that's, typically not how they work. We can have some improvement within a week or two. But that means typically that the SSRI has initiated a manic or hypomanic episode. So we want to screen and we want to refer to psychiatry before formal diagnosis and treatment. As much as I am a champion for primary care treating postpartum depression, we need those primary care folks to know how to use the MDQ so that their SSRI prescribing is done quite judiciously. For women that already have bipolar disorder, we want to do a lot of psychoed about this without scaring them to death, but we don't want to tiptoe around it. We want to encourage them to pay attention to the warning signs that they already know about themselves by making a plan, a wellness plan with their family and friends, stick to their social rhythm. The more we can keep the routine the same, the less likely we are to initiate a manic or hypomanic episode. Avoiding drugs and alcohol is a must. Taking medications if that person treats their illness that way exactly as directed, and using a very concrete wellness plan to minimize risk factors, as well as developing a crisis response plan, which is the suicide prevention approach we'll be talking about today in the event that the person does have suicidal thoughts. We're going to jump to postpartum psychosis now. So roughly 1 to 3%. I don't think the way, well, this is not just my personal opinion, the way we tabulate this data, I don't think we really capture it very accurately. It could be as high as 1 in 500. Because that 1 to 3%, we've just been sort of sitting with and accepting that stat in the literature for a couple decades. And we really need more studies that capture this more accurately. And again, we've got a 5% roughly suicide, 4% filicide rate with postpartum psychosis. Any of the mood disorders and anxiety or trauma and obsessive disorders could result in psychosis. Sometimes that gets diagnosed or coded as a brief psychotic episode. We have that peripartum onset specifier in our diagnostic coding that we can use. However, it is most associated with underlying bipolarity in the perinatal period. Postpartum psychosis typically begins fairly suddenly and shortly after delivery, usually with 1 to 3 weeks, but I have seen it in six months after. I've seen it later. I've seen people go in and out of psychosis for 6 months. Those are the folks that truly have underlying bipolar diagnosis that didn't get caught. The mood symptoms are often prominent. We'll see delusions of persecution, ideas of reference that are very common. Visual hallucinations are seen more often in postpartum psychosis than other psychotic illnesses. The delusions, when they're present, usually have to do with the infant, and that can result in either protective or abusive behavior or delusional protective behavior towards the infant or other children. Filicide is still relatively rare, but of course, when it happens, it's devastating. Hemiparity, meaning first childbirth, is a risk factor. Those that have a postpartum psychotic episode, at least 30 to 50% will experience it again with future pregnancies. So psychosis symptoms in the perinatal period, delirium-like presentation. So that's disorientation, disorganization, confusion, derealization, and depersonalization. Like I'm not really in my body. I feel like I'm watching someone else. Insomnia or decreased need or ability to sleep. Irritability, very common. I had a client who lashed out physically in the first few days, and forgive me if you've heard me tell this story before, but her family thought she was having a spiritual awakening until she became violent towards them a few days later. Abnormal thought content, delusions, hallucinations, abnormal mood, mania, agitation, depression, or like I said, mixed. You're often going to see mixed. Rapid mood swings, paranoia, hyperactivity. So just a quick quote from this wonderful guy, which I note here and again in some references at the end of the slides. This action on PPP pregnancy planning guide is, I believe, out of Australia. And this is a quote from a survivor quoted in there. Within days of being at home after 2 sleepless nights at hospital, I started accelerating into mania, but very different to episodes I'd experienced before. We often hear that from people who had pre-existing bipolar disorder diagnoses. I was very anxious and irritable 1 minute, singing and laughing the next, unable to sleep or relax, becoming paranoid and hallucinating. It was several more weeks before I felt well again.
Me,
Really?
Rose, we got a few questions in the chat before we
Okay.
move on from
Yeah.
the postpartum psychosis. The first question is, I think it's in reference to the prevalence of postpartum psychosis. Someone's asking, is it 0.1% or in parentheses 1 in 1,000?
Yeah, I'm sorry if I didn't make that clear. It's 1 to 3 per thousand.
Thank you for the
Yeah, it
clarification.
said 1% to 5%, I think,
Oh, I'm
the
sorry.
prevalence. Yeah.
Oh no.
Yeah.
Oh gosh, you're right. I misread that. I meant 0.1 to 0.3. I'm so sorry. Thank you for catching that error. I'll fix that.
And then another question we have is hypomania what a layperson might describe as depression, or is it just mania that is in the moderate category?
Mm. So hypomania wouldn't look like depression. It actually looks like elevated mood. To the layperson, it would actually look like someone who is feeling better than usual, more energy, more talkative, more productive, um, could could spend several hours up at night, like painting a whole room, but that could also be mania. So it's difficult without me going to that other presentation where I like go through the criteria distinguishing mania from hypomania. They look very similar, but it doesn't look like depression. And that's why people with bipolar 2 often don't want to be treated versus bipolar 1 folks are usually open to be treated because when they're manic, it's a more extreme version. They tend to do things they regret, like spend $10,000 or buy a new car, or like I said, have multiple sexual partners and perhaps end up with an STI. Um, so the mania is much less functional. Hypomania is pretty functional. Depression for either group, bipolar 1 or 2, people that have that diagnosis, can still look quite severe, mild, moderate, severe. That those major depressive episodes for those folks will be what you would see as depression. However, remember that perinatally, depression tends to be an agitated depression involving more irritability, anger, rage, and anxiety than crying and staying under a blanket on the bed. So for that reason, it's harder to catch the depression piece in the perinatal population, but the hypomania is people are going to look like they feel good. Does that make
Yeah, thanks
sense?
for the clarification.
Sure.
And then
Anything else?
the last question we have before moving on is the suicide and filicide risk among all postpartum moms or just those with psychosis?
Just those with psychosis.
Okay, thanks for the clarification. And
Sure.
that's all the questions for now, but keep bringing them. These are great questions.
Yeah, they're great questions. I'm so sorry I made that mistake with the 1 to 3%. But however, it could be in the trainings that I've taken most recently, there's speculation that it could be much higher. So it could be 1 per 500 instead of 1 per 1,000, but still very different than what I had up there. So sorry about that. So one of the ways Sharma describes the presentation is kaleidoscopic. Most commonly of affective psychosis, meaning mood, with perplexity common. That's what I think when I think of perplexity, and are often rapidly and constantly changing, leading to the term kaleidoscopic presentation. Makes it a little more confusing. The content is often baby related, as we mentioned earlier, tends to be consistent with a bipolar 1 psychotic episode. As we've already mentioned, hallucinations, delusions, periods of delirium or mania, thoughts of harming the baby or oneself, irrational feelings of guilt, refusing to eat, thought insertion, the notion that other beings or forces, God, aliens, the CIA, etc., can put thoughts or ideas into one's mind. And then insomnia, although we really don't know whether that's a chicken or the egg effect. And then reluctance to tell people about the symptoms. Let me just look at how far ahead. Oh, yeah, it's going to take us a few symptoms slides to get there, but we'll talk about why that is. So the delusions typically fall in 3 categories: persecutory, percusatory, I don't know, I'm not saying that right today, believing someone's out to get her or them; control, feeling that someone else is controlling her body, has taking it over; and somatic, so such as insisting that she didn't have a child or was never pregnant. And those at highest risk for postpartum psychosis either have that previously diagnosed bipolar disorder or any thought disorder, schizophrenia, schizoaffective. There's a lot in the thought disorder category, so I'm just mentioning those. Any family history of either bipolarity, manic depression, or thought disorders of any kind. Women who have already experienced postpartum depression or psychosis have a 20 to 50% chance of having it again at future birth. So that's whether it's just unipolar depression or it's psychosis. Any other prior psychotic episode puts a person at high risk. And then the general consensus, again, is that postpartum psychosis is a manifestation of bipolar disorder triggered by the hormonal changes of childbirth. We tend to see 3 distinct symptom profiles: depressive and or anxiety. That is actually the highest risk in terms of suicide and filicide. And that makes up, of those people who have that 0.1 to 0.3%, 41% will have the depressive, 34% will appear more likely manic when they're psychotic, or agitated. So you're going to see irritability more common than elevated mood. So they're not happy, they're like really irritable and angry. And I think that's the presentation that we see more outward violence, although suicide and filicide, meaning like striking out at someone, versus the depressive, the suicide and filicide is often related to internal thought content about protecting the child or themselves. And then we have atypical, which is about 25%, or mixed. Those are the folks that are going to be very obviously psychotic because they have catatonia, they're not moving, they're not speaking, or they're extremely disorganized. So the depressive symptoms and psychosis, the combination of those two, are almost always a factor in cases that involve self-harm or harm to a child, especially hallucinations or delusions that command a person to harm their child or themselves. So we see it more often, and it's the most dangerous one. And then again, here's the risk rate. So that's the alarm bell one. And what we as clinicians and providers most need to realize is our ability to intervene in the prodromal phase of psychosis. So in terms of time, and this can look really different, that's why there's no like minutes or hours or days here, just depends on the person. There is an uptick in psychotic behavior and activity that begins, descends, initiates higher, descends, then it's obvious to other people. This is the window of time where a woman can sometimes realize that she's seeing and hearing and believing things that other people aren't, and might talk about it, and in here starts to hide it. Every postpartum psychosis study that I've read or person I've talked to experienced some version of that in the prodrome. So that's why psychoeducation is so important, because this is our chance to get people before they're in the acute phase and can be more danger to themselves and others. And this recovery phase, as was quoted by that mom, it can be quite long, weeks to months, especially if it's not treated with medication. So in terms of symptoms, you're going to see 73% of PPP, folks with PPP have that irritability. The vast majority will have abnormal thought content. The vast majority will be anxious. We do think that roughly 14% of these folks presenting, will actually have just had a psychotic episode discrete to the perinatal period, meaning they actually don't have underlying bipolar disorder. That's hard to know. And because it's such a scary thing and unpredictable, a lot of women will be put on mood stabilizers forever to prevent a recurrence. But we believe around this percentage, actually, they're only at risk when they have that dramatic hormonal fluctuation. So that's interesting and something to be mindful of, because that's a really hard diagnosis to come out of your newborn experience with when you never had a mental health history before. However, roughly 86% we believe meet the criteria for lifelong bipolarity 1 or 2. I'm not going to go into details with this one, but this is a really excellent chart on the proposed etiology from a hormonal basis of postpartum psychosis. And essentially, I'm just going to kind of read like some of these bullet points. Essentially, when we talk about the hormone changes, we're referring to, estrogen and how it mediates dopaminergic tone of the limbic system, that fight, flight, freeze. So the onset of postpartum psychosis is attributed to increased sensitivity of dopamine receptors. Women at risk for postpartum psychosis may have differential sensitivity to rapid changes in the plasma concentrations of these hormones rather than having altered peripheral levels. So it's the change. And this is true for postpartum depression as well. Some of us have what I call hormone-sensitive brains. In particular, folks, it will lead, rather than to just depression, a psychotic episode. So neurosteroids such as allopregnanolone rapidly decline following baby's birth, which can affect GABA receptor plasticity, resulting in an imbalance between excitatory and inhibitory GABAergic circuits. So if you're not a physician or a psychiatrist, that might not mean a lot to you. But if you know what Zulresso is, it's the only FDA-approved treatment we have for postpartum depression. It is one metabolite away from allopregnanolone, metabolite of progesterone. And that inhibits those GABA receptors and affects depression in unipolar depression as well. So that's just, if you want to go back later and look at these slides, if that'd be useful for you, that's just kind of the hypothesis that we're working on now, working with now in terms of why this happens to some women and not others. Also, very important, of course, to rule out any other etiology related to psychosis, and there actually can be a lot. You want to do a CBC and a BMP, CMP blood panels to rule out any electrolyte imbalances, infections, bacterial stuff you've got going on. Vitamin and mineral deficiencies or excesses can actually cause psychotic symptoms. Impaired kidney or liver functioning certainly can, as we've already mentioned, drug and alcohol abuse, or even just use can. I will tell you, I'm seeing more and more clients who are coming to me in a state of prodromal, like in and out of psychosis, non-perinatally, who have used psilocybin mushrooms or LSD, who never should have, because they have first-degree relatives with bipolarity, and they're in an episode that they cannot get out of, certainly not without medication. And we need to be talking about that more. Imaging of the brain, CT, MRI, can help us rule out the causes such as a tumor or a lesion on the brain, other things that can be going on. Treatment and recovery usually involves hospitalization, medication, therapy, etc. It is a psychiatric emergency. Recovery takes quite a lot of time. And atypical antipsychotics, mood stabilizers, anti-seizure meds are all used to help people recover. It may be paired with an SSRI, however, typically not, at least not initially, simply to avoid that mania risk. However, I do see it prescribed with a mood stabilizer, and any prescribers in the audience maybe at the end could chime in with how they see treatment going. That would be helpful for us to hear. Important to remember that this event is a reproductive trauma in of itself, and the grief and losses of how the unfolding of the birth and postpartum window unfolded or did not unfold really need to be processed and grieved. A person will need a solid trauma therapist in the days, weeks, and months following discharge from psychiatric admission related to psychosis. We can use rewriting the birth, psychodrama techniques. I do a lot of EMDR with folks who've had reproductive trauma of any kind, including psychosis. Creative visualization, meaning we redo the whole thing the way she had hoped it would be. Having a ceremony and ritual, using those techniques to honor the death of that fantasy and accept the new reality. And, just educating the family and the patient or client that this is a process is really useful. Here's a link to the Postpartum Psychosis Project at Mass General. They collect survivor stories that can be really normalizing for people. They have excellent guides for families. Postpartum Support International at this page has lots of resources. These APP planning guides are the ones out of, I believe, Great Britain, that are just excellent. If we have time, I actually have them on my screen. I can kind of show them to you. There's a preparing guide and then the recovery guide and some other great information. So we're about to talk about prevention. Any questions before we do that?
There aren't any questions in the chat, but if anyone has any that are on the tip of their tongue, go ahead and speak up.
Okay, we're going to go through this relatively quickly. So this is not like a clinically proven model. This is my model. It's just an acronym for what I believe if we use all the evidence-based material that we have, how we can put it together and reduce harm, reduce risk. So it's empirically based, it's a clinical approach, really looking at risk factors, focused on assessment, it's collaborative and client-centered. It emphasizes biological factors and psychoeducation over anything else. It is evidence-based, but it's not clinically validated yet. It is based on clinician experience, mine and others that I work with, and it is a proposed model for further research. So this is what the acronym stands for. We've gone over this. I'm just putting it together. So assess for personal and family history, mental health conditions, suicidality, psychosis, etc. Screen well, protect sleep, initiate medical prophylaxis, and treat to remission. That is very important. We're going to go by these slide by slide. So don't worry if you're not getting all this. Referrals and resources, educate, and see something, say something. So when we're assessing, again, family history, suicide survivorship, I had a client who's had up 12 people in her close immediate family or friend group die by suicide, super high risk. Any history of any mental illness of any kind. Remember, positive family history with a negative personal history, and they're a first-time parent, higher risk, because we're looking at that first episode postpartum again, which is noted here. And then remember your differences between OCD and psychosis. Did I go past that? I must have it. I have it down here somewhere. We'll talk about that in a moment. And then again, family or personal history of bipolarity and thought disorder equals the highest risk. We got the EPDS and the MDQ to use. Here are a couple other screening questionnaires, which are useful clinician-rated dimensions of psychosis, symptom severity when it's suspected, and bipolar prodrome symptom interview and scale. If you're interested in catching those prodromal symptoms, that is available for us. Protecting sleep is essential. The longer we go without sleep, the higher the rate is of psychosis for unipolar or bipolar or any other condition for that matter. It's essential to minimize hospital interruptions. That's a systemic change that we really have to see if we want to improve mental health outcomes in perinatal people. We need to support feeding assistance from day one because that is a huge determiner of quality sleep, whether nursing is going well, whether it's painful or not. And the goal is 4 to 6 consecutive hours as soon as that's safe for baby. Some women might choose to not breastfeed even if they wanted to, if they have existing bipolar or major depressive disorders, depending on how sensitive they are to sleep. That is a very personal decision that needs to be made on a case-by-case basis by the woman or birthing person and her family and physician, which means we got to reevaluate that breast is best messaging, which clinically is true in terms of nutrition for babies, but babies need an alive and healthy mom, obviously, as well. And I would argue more than anything else. That's my personal opinion. Initiate medical prophylaxis and treat. We want to identify these. And that might mean with using mood stabilizers and SSRIs, but we also need to know alternatives. There's a lot of people that have had horrible side effects from those drugs. They don't want to take them, or they didn't work, or they caused suicide in a youth or someone else in their life. So we need to know the nutritional functional medicine approaches as well. Lithium orotate is something some of my clients who don't want to take lithium or Lamictal take, and that actually has worked for them. There are alternatives. In my opinion, I've seen them. We have some studies. They don't make pharmaceutical companies money, so we don't see a lot of good data, but we have to be able to have the conversation and not assume that just because we think someone should take medication that they're going to. So continuing mood stabilizer if they're open to it or reinitiating immediately after birth is a very good idea. We want to utilize that motivational interview to know how likely are these folks to actually do the treatment that we want them to. And again, lithium has the most evidence behind it with regard to preventing mania and psychosis. We want to give those referrals and resources early. These are all that you're probably already familiar with. Social rhythm therapy is what we use for treating bipolarity. If you're not familiar with it, that's a very helpful thing to know. Using the Department of Health Sunshine handout is a great way to do wellness planning. We want to educate everything that we've talked about. We want to help people understand. We want to give them very simple guides. We want to distinguish between OCD and psychosis so people don't get alarmed if they have intrusive thoughts of something bad happening to their baby at their own hands or someone else. That is not psychosis if it bothers them. If the thoughts are ego dystonic, if they're aware that those thoughts aren't something they want to act on, they're not psychotic. So that's something we need to talk about before. And again, educating what prodromal symptoms look like, providing crisis numbers, and making a plan for anyone at risk. And then, of course, seeing something, say something. Like we don't want to pretend like things are normal. And in well-known cases, even in Utah, of people who killed themselves or someone else, a child, when I talked to family members later, they saw something, but people were too afraid to say, I think your wife is having psychosis. It's always better safe than sorry. So this is just taking this and creating a timeline around it. There's nothing really terribly new here. Best to err on the side of caution. Talk to your colleagues. I don't advertise this, but I will take any phone call from a colleague who wants to run something, a situation by me, and get some advice or my thoughts based on my experience. And then we're going to talk about suicide risk. So this is an old book. I've said it probably every training I've ever given, but this piece, the woman who thinks her baby will be better off without her is the highest risk for suicide. So it's actually a question that I ask people when they are clearly meeting criteria for major depression of either kind. This is simply a link to best practices registry for culturally competent approaches to suicide prevention that I don't have enough time to go into right now. But it's really important to remember that when we're talking about mental health in general, and particularly suicide, if you happen to be white or of a certain religious affiliation, we can't assume, obviously, that anyone else thinks about mental health in the same way we do, and we want to get outside education on understanding that. So to make it really simple, we want to use screening tools to help us with differential diagnosis. We want to educate the patient and the family. We want to be consistently checking the progression of healing versus illness and always and regularly assessing for any suicidal ideation. And we always want to have a plan for a crisis that will involve crisis response planning. So you've recognized risk. Now what? What do you do? That means they've scored yes on number 10 that asked them about self-harm. Their family is worried. The patient discloses self-harm thoughts or behavior or a recent attempt. The patient has worsening symptoms despite treatment. They're in crisis. They don't feel safe. This is for lay people. This is great for all of us. This is what we do clinically. But go back to your earliest training. Frequency, intensity, duration. How often? How many? Last 2 weeks. How intense do they seem on a scale of 1 to 10? This is when we assess for access and means. How would you do it? Do you have a gun? Do you have the keys to the car with you? Do you have medications in your house? How long does that intensity last? My favorite crisis response training, suicide prevention training that I've taken was from Dr. Craig Bryan at the U of U at the VA. And he once told a story about, someone fleetingly thinking about this while driving a car versus a man. He said, like, how intense is it? Like, and what are you doing? Well, it didn't last. It was really intense, but it wasn't very often, and it didn't last long. But what he was doing was holding a shotgun in his mouth while he had the thoughts. Those are the kind of details we have to ask. So we're assessing for these general things. What kind of support? How often? Do they have any history? Do they have family history? Do those thoughts bother them? Do they intend and plan on doing this? And we got to ask those really hard questions so that we can develop a good crisis response plan for them. So these are some examples of questions I would ask. This will help you differentiate between active and passive suicidal ideation. And even before we get to crisis response planning, you're just opening up the dialogue here. What do you think you need to be safe? That's one of my very favorite questions, because if they're talking to you about it, they're not hiding it to the degree that they've decided this is what's happening and there's nothing you can do. So we have a window where we can ask these questions to try to get people as safe as possible. Does anyone know how you feel? Can't tell you how many times the answer is no. I have not disclosed the depth of my depression to anyone. And that's at that point, I'm like, let's call your partner right now. Let's see if they can get them or your mom that lives, down the street. Let's get them on this call and share that. Would you be willing to do that? And if not, who else could you connect with? So you don't have to hold this alone as we make a plan. So we can harm patients if we overreact to these situations. And, learning this kind of information or hearing it just, again, or for the first time is enough to get us be like, yeah, sending everyone to the hospital. And we don't need to do that. Someone with no or very low risks would be an example would be someone with OCD that's having intrusive thoughts of killing themselves, but they clearly don't want to do that. Or hurting their baby, but they're disgusted by those thoughts. They have graphic intrusive images. That's not high risk of suicide unless those symptoms are driving them to that and they feel so out of control or such like a bad person that they're considering killing themselves to end their OCD symptoms. But those are two separate issues. They're oriented to self. They don't have severe comorbid depression. They don't have history of all these things. A moderate, and by the way, this is just like my general sense clinically. This isn't like documented or studied anywhere. This is just a sort of clinically as a provider, how to think about, low, moderate to severe or to high risk. Moderate or high are going to be, you've got intrusive thoughts of hurting yourself or someone else, plus severe comorbid depression and feeling rage, out of control, high degree of emotional reactivity, severe insomnia, you add that. But the feelings of harming the baby or themselves are disturbing and they want help. Okay, so we're in the moderate range, probably not immediately hospitalizing this person. This one we probably are. This is someone who has thoughts of harming the baby with an active plan to do so or themselves, and they're not willing to safety plan. Those thoughts make sense to them. They're egocentric. They have uncontrolled anger towards the baby with poor insight, evidence of abuse. Perhaps they're also actively substance using or abusing, and they're resistant to intervention or treatment. Maybe they have a family history of psychosis, thought disorder, bipolarity, et cetera. That's someone that probably needs to be in the hospital. Someone who's psychotic does need to be right now, that unless they have like a psychiatrist already on the line with them, they can just go take a medication they already have. It's a ride to the hospital. And sometimes an ambulance ride is safer. It just depends on the situation. So it's the functioning. The functioning is highly impacted. Patient doesn't feel safe for themselves, even if they're really cogent, but they don't feel safe. You already know that's a time to go to the hospital. Unless there's clear evidence of abuse, we're going to harm people by calling DCFS. I have made many of these reports in my career. I'm not encouraging you not to make them if you are a mandatory reporter and you have good reason to do so. But enlisting 211 and Help Me Grow and referring to needed services that will support parenting skills, child development education, that's going to help our clients and patients a lot more. So some therapeutic considerations. Perinatal suicidal ideation is often a crisis of meaning and feeling because they have depression or anxiety, they're a burden. And they don't matter. They're not important, especially if this person also has an extensive trauma history that they have not done any healing work on. A lot of shame, sexual abuse trauma comes up after pregnancy, labor and delivery, breastfeeding, like so many crises of meaning, worthiness comes up. So helping folks connect to the image of a baby's inherent lovability and worth, they're not doing anything, they're not productive, has been helpful for me in helping people recognize that the parameters they're applying to themselves around really deserve to live, they're not applying to anybody else, especially their children. And I know this sounds kind of wacky, but giving her the option to end her life later, reminding her she can always do it later, but let's buy you some time till you can remember that you matter because you're the only one that can't see this right now because of the illness. Also remember that sometimes just doing therapeutic work perinatally can bring up SI because you're facing what in internal family systems we call exiled parts. We used to call them inner children or parts work, or it's basically repressed material, repressed, denied emotional experiences. When we start to work with them, sometimes they can overwhelm the system. We simply ask them not to, and they settle down because when they're overwhelming, they can lead to SI. So if you're a therapist, utilize resourcing, utilize thought diffusion, utilize your containment strategies to help folks with overwhelming affect so they can do their trauma work without becoming suicidal. I do believe clinically it is important to acknowledge suicide is a choice and to normalize those as sort of escape fantasies that are coping strategies from enormous emotional pain. And those decisions about life and death can be made later when we're not in crisis mode. I tend to affirm people's worth without being productive or contributing or being of service to others. That's a really big theme with mothers. And I always bring up macro level systems issues, like, this is often a result of really unrealistic expectations that systems place on us, or just the reality that childcare is so expensive, or that two people have to work to pay the bills these days, that it drives us to a point where our bodies can't handle it anymore. And so we start to have these thoughts just to cope and to try to figure out a way out. Expectations from motherhood and perfectionism need to be explored. We just need to remind folks that suicide is permanent. It can't be reversed. And we actually don't know that it guarantees relief. We just don't know. Nobody knows. If you pretend like I don't believe you. It limits all other choices if anything changes in the future. So I might say something like, is it possible there could be limits to your thinking right now? What would it take to give you time before taking away all other options? And then just ask, do you have thoughts that are scaring you? Any thoughts about hurting yourself, your kids, someone else? It's not unusual for women, I see, to have thoughts of harming their child. So I ask everyone. Sometimes we feel so angry, anxious, overwhelmed. We just want the baby to go away. Have you ever felt this way? Then we assess for risk. And of course, look for observable signs of abuse and neglect. We want to make it a safe place to be like, yeah, I screamed at my child, or I squeezed my child too hard and I feel so bad and I never want to do it again. And give them tools, not shame them, because especially with the mood or anxiety disorder, honestly, even if you don't have that, I don't know a parent that hasn't at times felt like, hurdling their child across the room, because it's the sleep deprivation. If you're sensitive to it, it's just, you're done. You don't have the resources to cope. So if you're a psychotherapist, or if you're not, you want to refer to some place that people can get tools to calm their own nervous system to deal with those overwhelming feelings. So here's just some languaging to talk about suicidality. We've already covered this. To really quickly, I'm just trying to wrap things up here in the next 5 minutes so we can do more questions. To just clarify, the OCD is basically an overprotective mother that's thinking about the worst case scenario and having intrusive thoughts that are ego dystonic. They don't make sense to them. Brooke Shields, many years ago now, went on Oprah and talked about having postpartum depression and how she had these images of throwing her daughter against the wall. That's not postpartum depression, that's postpartum OCD. That didn't help our field a whole lot. Andrea Yates, unfortunately, when she was psychotic, really believed she was actually saving her children by killing them, killing her 5 children in the bathtub. OCD doesn't turn into psychosis. It's a discrete diagnosis. Someone with OCD could still have psychosis, but it would be from some other etiology. The OCD, the intrusive thoughts are different and discrete. Many women have been reported to DCFS or have the police called when they have OCD for suspected psychosis. So that's why I always include this slide. Contracts, safety planning, like contract not to kill yourself, they don't work. Don't do them. Crisis response planning does. So when people are talking about suicidality to you, we want to say, like, this is a really common symptom of the illness of depression or bipolar disorder that you're having. Let's make a plan. Thoughts are different than actions. Your baby's so lucky to have a mother or parent brave enough to reach out for help. So the crisis response plan that we're going to go over really quickly here usually takes 20 to 40 minutes. It's strength-based. It's focused on calming and coping. It's not a substitute for treatment, but it's part of treatment. And I do this all the time, even with people who are not suicidal. So it focuses on recognizing warning signs, employing existing internal coping strategies without needing to contact anybody else, socializing with others who could offer support and distraction, contacting family and friends who can help resolve a crisis, contacting mental health providers, including 911, reducing the potential for use of lethal means, and focusing on reasons to live. This is an adaptation of Stanley Brown Safety Planning Intervention, and it looks like this. And I'm really curious because I can't see you. When we're done, I would love, if you already do this in the chat, it would be really helpful for me to know if you're already trained in CRP planning and what you do. So this is actually an example of this is what their warning signs. I just start thinking of suicide, warning signs that I would kill myself. That's what the CRP is for. But you can adapt it for use of lots of things. I argue with my spouse. I had the urge to drink. Self-management. I say like, well, you haven't killed yourself in the past. How did you not do that before? What did you do? Deliberate breathing. I took a walk. I put on a funny movie that I like. Social settings. Where could you just go or be to just be around other people, be socially connected? Because we know isolation does not help. Go to a movie theater, sit at a mall, go to a park. Social support, mom's number, partner's number, neighbor's number, friend, professional crisis support. There's my therapist, hospital, 988. That's a national suicide lifeline. I always have people put 911 here. They say, I'm not going to do that. I'm never going to call 911. When you're thinking of killing yourself, your cognition declines. So I'm always talking about this with my clients. This limbic brain is the bridge between the two hemispheres of the prefrontal cortex. When this is activated, as is in suicidality, that bridge goes up and you can't think clearly. So you just follow your plan. That's why this works. This is the most evidence-based way of preventing completed suicide because people just follow their plan and they made it. And then environmental safety. I'm going to remove the weapons. I'm going to have the pills with the neighbors. If I need, an oxy for my back, I'm going to go to the neighbor. They're going to give me one. And then the last is reasons to live. My dog. People usually put their kids here. Sometimes it's a place they've been to that they love, sunsets, a vacation they've always wanted to take, etc. So we're kind of here at the end. These are the best options in Utah for active suicide plans. I think everyone has this, him, he, 911, obviously, 988, again, one can text or call. That's the National Suicide Crisis and Lifeline. All those suicide safety planning resources are here. Here is who I had what I consider the absolute best 2-day training by several years ago. That was actually sponsored by the Department of Health, and I was able to attend, and it was absolutely fantastic. I wanted to let you know that we have this CALM protocol here in Utah. Firearms are the leading suicide method in Utah, responsible for half of suicides. Most gun deaths in Utah are suicides. And counseling on access to lethal means is a brief intervention that healthcare professionals can undertake to reduce access to lethal means. If you want more training on that, there's the link for that. And that they do offer CEUs for physicians and social workers. Here is the National Maternal Mental Health hotline as well, providing services in English and Spanish. I'm not going to go over these. These are just some psychiatric hospitalization considerations. You'll have them in the slides. This is just some language I use for fathers who score over 6 on the APDS. Here's some local resources, and then thing on making referrals. You already know this, how to find perinatal psychotherapists in Utah, hopefully. Here's further reading. Some of those guides that I referenced are here. Here's my citations. I did not have time to put them in APA format in an alphabetical order. Please forgive me. And then I have gone back to making YouTube videos. I have 2 videos on suicide. This is one on preventing your own suicide. And oh God, no,
Hi,
no,
dear ones.
no.
Thanks for being here today.
And let me see if I can go to the next slide. I rehearsed this and it worked. Crap. Anyway, I have one on surviving suicide loss that's after this, but I'm not sure what's happening. It's not letting me go there. Oh, there we go. So here's my suicide loss one. Okay, that's it. Thank you so much for listening. Any questions?
Thank you so much, Amy Rose White. I know I learned a lot, and I actually did have a question that I think you may have answered for me. My question was, if you have someone who has experienced mental health conditions in the past and they are wanting to start a family but are really concerned about experiencing severe perinatal mental health conditions, was the thing that you would recommend doing is the crisis planning?
Yeah, it's the wellness planning first. Crisis response planning is more specific to I'm going to go use a bunch of drugs or I'm going to harm myself or someone else. Wellness planning is more like, okay, well, let's talk about what has helped you before and what is the biggest influence in your mental health declining. So a lot of people say like, I know it's my sleep, or I know I just can't be with the baby all day at home, or it's when my partner's traveling. So someone that has a significant mental health history kind of needs to take that information and do what we call wellness planning. So they want to work with a provider of some kind. It really doesn't matter who, to go over sleep, nutrition, social support, their spirituality, their exercise. I'm sure I'm forgetting something that I put on there, and what that's going to look like before, during, and after baby, and then having everyone on the team be part of making sure that happens. Oh, hydration. I forgot hydration. So a lot of the stuff that's on the Sunshine handout, we can use to build a wellness plan for people. Sometimes it means staying on their medication. Sometimes it means adding new medication. Sometimes it means determining they're not going to breastfeed or they're going to breast, it's so individual, but it means sitting down with someone that really knows you.
Yeah, that makes a lot of sense. Thanks so much. Because
Yeah.
it's kind of funny, like I'll be vulnerable here, and that makes me concerned too. Like I'm still young, I'm not in that phase of my life, but I'm like, oh, just learning so much about this. It kind of scares me. So wellness planning.
I know that's the downside of, even talking about this, because I realize that it brings up a lot of anxiety for folks. And the reality is, life is hard, life is complicated. We can get hit by curveballs, here and there and everywhere. And if we're, knowledge is power. So if we know what things look like, we know what the tools are. And just remember that fish oil, staying on your food-based prenatal vitamin, drinking 2 pitchers of water a day, trying to get 4 hours to 6 hours of sleep as soon as you can, just like for non-pregnant people, like those are foundations of mental health that we all can use to say, okay, I can see X, Y, and Z is kind of missing here. How can I get support to plug that back in? And from that place, we just had the attitude of whatever comes, I'll handle it. I'll handle it. I know where to go.
It's great. So we just launched a poll just while we're waiting for other questions to come in. This poll will take probably 30 seconds of your time at most. It's just asking to indicate your overall satisfaction with the setting and how it will change your practice as a result of attending the training. So this really helps us to understand how we can improve for future learning sessions, and we appreciate your time to take this. We do have a few comments. We offer it helped me grow as a screen positive on question 10 or show risk otherwise, but many choose not to create one. We always send a template to them and go over Sunshine, encourage social support, etc. This is the EPDS, I'm guessing.
Yeah, and that's why, Ilsa, I mentioned Help Me Grow on like 3 different slides, because I know you do that.
Thank you so much. Yeah, we do continue to offer it, but they just don't always want to. But I'm thinking at least they have an empathetic person on their line that emphasizes, to tap into their social connections and into their wellness routines as much as we can. So, yeah.
Absolutely. Thank you so much for doing that.
Have other comments to say this was incredibly informative and this is such important work that you do. Thank you so much.
You're welcome. Thank you.
Another says a lot of students have the same concerns. I'm guessing to the concerns that I brought up of, wanting to have kids one day, but worried about having perinatal mental health. But I know at least one who is very concerned and now a mom of 2, and she learned along the way. Yeah, that's really great. Another thank you so much. Any other burning questions that we have while we have Amy Rose still on?
Well, I guess I do want to check. I don't know. We currently have the capacity to Help Me Grow to change our protocol majorly. But Amy Rose, I'm wondering, given this information, and the more and more recent information about the risks of bipolar and possibly screening for that. So I hear you say you are, recommending to screen for bipolar symptoms for sure at medical clinics. But how about Help Me Grow or similar organizations who are not medical? Do you recommend adding a screening for bipolar or possibly screening for psychosis? Or suicide risk. What are your current thoughts on that?
Specifically in the Help Me Grow and setting.
Yeah, I mean, yeah, let's just take that because non-medical for sure.
If it makes sense in the context, it's important data if your caseworkers know how to take the information and translate that in a way that's useful and meaningful and not overwhelming, terrifying to both the caseworker and the person receiving the information. So it's a little, I think it's getting into territory that obviously is more clinical. I do think it would help us reduce risk in the sense that we say, hey, you had the score on this. This just tells us that you're a little bit at higher risk of having a kind of depression that will get treated differently. And that means it would be a really good idea to talk to X, Y, and Z provider. So I just, as long as the conversation doesn't go any further than that, I do think that it would go a long way because I missed so much of this. I mean, that's why I'm telling you this. Like this, I learned the hard way. I missed bipolarity for many years in my work because I wasn't asking the right questions early on. And I do think when it comes to risk, it would behoove us. We just have to have people be comfortable enough. I mean, people don't want to talk about suicide to begin with. And if they're not clinical providers trained in diagnoses, you just want to say like, okay, you scored this on a screening questionnaire that then tells us, would you be willing to talk to somebody else? And I know how hard it is to get someone to that next warm handoff to like, what do you mean there's something wrong? But people who are calling Help Me Grow they're wanting the best for their baby. So I think it could be used in a motivational interviewing sense to say like this, you'll be able to meet your goal if you get the right help for you. And it would be great information during your pregnancy. Just know some certain warning signs to look for you might be at higher risk for simply because of how you answered this questionnaire. So it's yes, with a caveat to all the reasons
Thank you. Yes, exactly. And we do make sure to send informational resources on like, for example, if we hear them say that they had bipolar in their past or a risk for that, we would definitely send them an information sheet like from PSI or something. Yeah. So thank you very much.
Yeah, those PSI informational sheets are great to just give people an overview of like, do you think any of this is happening, or share this with someone in your family? Do they think any of this is happening? And psychosis is on there. So I think that is a better approach with that population, a non-medical population, than actually using clinical screening instruments for things like psychosis or even substance use disorder. Like I think it's a little out of context, but it's very relevant information nonetheless. Thanks for the question. Anything else?
I see another comment in the chat. If my clients are socially isolated, I see them more often when they are pregnant.
Excellent. Wonderful. Yes. Any, PSI has umpteen million online support groups. I usually try to connect folks to those, even just practicing social skills. But yeah, therapeutically, if we can have more involvement, that's great. Encouraging people to be in their community around people is helpful. When they're struggling with a mental health crisis or just an illness in general, it's tough because they're not getting a mirror of their experience if they go out socially. So I really love hearing that because oftentimes the therapist is the only person that's like, this is totally safe to admit you're not enjoying this, or this is really hard, or you're going through a marital crisis at the same time you had a baby. And, you don't want to share that necessarily with your inner circle. If people are even lucky enough to have an inner circle, and post-COVID, there are many people who are still extraordinarily isolated. They don't have friends. It didn't come back for them. That's a tough place.
Yeah, absolutely. We do have time for one more question. I did get one in the chat here. How do you deal with how do you deal with treatment resistant family when your client needs meds or hospitalization?
So the client one is open, but the family is not.
Correct. Or
Yeah.
I guess I don't know if it doesn't specify, but um, okay, yes, that's
Yeah.
correct.
Yeah. Okay. That's so hard. I mean, I try to do as much psychoeducation as I can, and I remind the client, I ask them what their priority is. Like, what do they want for their child? What's the most important thing for you, for your child? And it's usually that my child is okay. My child is well. My child is healthy. My child is happy. And I say, okay. For that to happen, they have to have a well mom. That's why my old agency was called Well Mom. They need a well mom or well parent, however they identify. This is the course of action that I believe is absolutely necessary to give them that. How can I support you in being well, even if your family is not on board? Who else can we pull in? Can we get your doctor, your therapist, your acupuncturist, like whoever is, in your court and sees that you have a crisis requiring something more, higher level of intervention, including medication. I also remind people that their treatment is private. They don't have to disclose. I have a lot of clients that are just very open and they want support and they want their parents or their grandparents or obviously their partner. That's the hardest one when the partner is not supportive of medication or hospitalization and it's really warranted. I just say, you have the right to keep certain things private. You have the right to the medical care that is right for you and true for you. And you don't have to share the details if you don't feel comfortable or you don't feel supported or validated right now. You could make that decision later when you're out of this crisis. Right now, we need to focus on what's going to keep you on the planet and as healthy as can be so you can take care of these kids.
Thank you so much for answering that one last question for us. It is 1:30 and want to be cognizant of everyone's time. Amy Rose, this was so informative. Thank you so much for being here and doing this presentation with us. We really appreciate it.